Hi everyone, this is Nafis, and welcome to another episode of Medical Mayhem. This video was actually inspired by a case shared by Dr. Sam Galley on his Twitter account. I included a link in the description below. Anyway, let's get right into it. A 17-year-old boy with a history of asthma presents with severe respiratory distress. He was found by his brother having the worst asthma attack of his life. You can see deep retractions, and there was a bluish discoloration of his lips and tongue. You can hear loud wheezing as he struggles to breathe. In terms of his vitals, he's tachycardic with a heart rate of 132 beats per minute, tachypnic with a respiratory rate of 40 breaths per minute, and his oxygen saturation is dangerously low at 30%. His eyes roll back and he loses consciousness right in front of you. So this patient is obviously in serious respiratory distress. He's struggling to breathe and his oxygen saturation is tanking. So we have to act fast. The question is, what should we do? Should we intubate him? No. It's often a knee-jerk reaction to see a patient with a declining respiratory status and think that intubating them and getting them on a ventilator is the best thing to do. But that's not what we should do for a patient that's experiencing a severe asthma attack, because it does nothing to address the underlying problem. Let's talk a little pathophysiology. When it comes to your airway, air from your oral cavity goes down the big tube, your trachea, and eventually splits into the two bronchi that go to your lungs. The bronchi divide into smaller airways called bronchioles, and then those end up as little air sacs called alveoli. The alveoli are surrounded by little blood vessels, or capillaries, that take oxygen out of the alveoli and bring it into the blood, and move carbon dioxide out of the blood into the alveoli so that it can be exhaled. If we focus on the bronchioles, we see that they're lined with smooth muscle cells that contract to make the airway tighten up. Conversely, the smooth muscle cells can relax to make the airway open up. When you're in fight or flight mode, you want it to be the latter. You need your airways nice and open so that you can breathe easily, either so you can fight or run away. In fight or flight mode, you get a surge of molecules called catecholamines, like epinephrine, that bind to receptors on the smooth muscle cells lining the bronchioles. These are called beta-adrenergic receptors. When epinephrine stimulates these receptors, it makes the smooth muscles relax. That opens up your airway and you can breathe easier. When you're in the opposite state, like when you're just chilling on your couch watching Netflix or rest and digest mode, you don't need your airways to be so dilated. And you instead get a lot more of a molecule called acetylcholine that binds to another kind of receptor, the muscarinic receptors, on the smooth muscle cells. That makes them contract this time, and the bronchioles constrict as a result. This constriction of the bronchioles stops foreign stuff from getting in your lungs. You also have glands in your airway that secrete mucus, which keeps things nice and moist and catches things that are in your airway that really shouldn't be in your airway. And that foreign stuff gets coughed out as phlegm. These glands also secrete mucus in response to the muscarinic receptor. So the two things that happen in response to a foreign body in the airway are 1, smooth muscle constriction, and 2, mucus secretion. And that's mediated by the muscarinic receptor. In asthma, the airway gets irritated by something, like pollen or mold, and you get those two responses that you would expect. But the problem is, this time things go into overdrive. You get an exaggerated response, where there's tons of inflammation, which leads to excessive constriction of the airways, or bronchoconstriction, and excessive secretion in the airways, bronchuria. The tube gets narrow and there's a buildup of mucus that can plug it up too. The result is, when you inhale, air can go in easily and get past the obstruction as the airways open up, but as you exhale and your airways get smaller, the air gets blocked by the mucus plug and is trapped in the lung. The small amount of air that does manage to squeak through that narrow opening does so forcefully, which creates the wheezing sound that's characteristic of asthma. Remember this, asthma is mostly a problem with exhaling, not inhaling. So when all that air can be breathed in, but can't be breathed out, you end up getting really severe overinflation of the lungs. The little air sacs at the end of the airways get overdistended to the point where they can burst, and air rushes out as a result. This damage from increased lung pressures is called barotrauma, and obviously we want to do whatever we can to prevent this. So why don't we simply intubate this patient? Remember I said, it doesn't address the underlying cause, and asthma is primarily an issue of exhaling air. So when you're using the machine to bring air into the lungs, you get profound hyperinflation of the lungs from severe air trapping. With each breath delivered by the vent, the air just piles up and piles up, and barotrauma eventually becomes inevitable. But the question is, what do we do instead? Well, the first and easiest thing we should do is position the patient. We should get him in an upright position at 90 degrees, as this is a position that decreases the work of breathing, probably because the chest cavity doesn't have to work against gravity to expand like it does when you're lying down. Okay, so we've positioned him upright. Easy enough. Now what? Well, he's starved for oxygen and his airways are closing up, so we should probably do something about that. We have to deliver oxygen to his lungs by putting a mask on him that provides something called bilevel positive airway pressure, or BiPAP. Bilevel means there are two pressures that the ventilator provides the lungs, one on inspiration when it's sending air into the lungs, and one with expiration to keep the little air sacs open when the patient breathes out. The former is called the inspiratory positive airway pressure, or IPAP, and the latter is called the expiratory positive airway pressure, the EPAP. The IPAP supports ventilation, but you have to keep in mind that the higher it is, the greater the volume of air the machine sends to the lungs, or the tidal volume. The greater the tidal volume, the more air the patient has to exhale, and you hopefully know by now that he isn't very good at exhaling. So striking that balance between keeping the IPAP high enough that it's getting adequate air into the lungs, and keeping it low enough that it's not causing hyperinflation and barotrauma is very tricky business. Let's say we start off with a BiPAP of 14 and 4. 14 is a reasonable IPAP, not too high and not too low, and the EPAP is low at 4 to also avoid barotrauma. We'll revisit these numbers in a bit to see if we can get that IPAP even lower. Other than oxygen, what else do you think we should be making him breathe in through that mask? Well, if we zoom in on the airways again, you'll recall that the smooth muscle lining has muscarinic receptors that make them contract, which constricts the airways, as well as beta-adrenergic receptors that make them relax, which dilates the airways. The muscarinic receptors are also present in the glands that help them secrete mucus. We want to tip the scales towards the beta-adrenergic receptors to open up the lungs. If we can activate the beta-adrenergic receptors and block the muscarinic receptors, we get bronchodilation and less mucus secretion, making the airways nice and open. We can stimulate the beta-adrenergic receptor with a beta agonist like albuterol or epinephrine, and block the muscarinic receptor with a muscarinic antagonist like ipratropium. But what about the thing that started this mess in the first place? All the inflammation in the airway. Steroids are really good at reducing the inflammatory response, and are usually the go-to for any kind of inflammation. In this case, corticosteroids like dexamethasone and methylprednisolone are good options. So with the oxygen, we should make him breathe in some combination of nebulized albuterol and ipratropium. On top of the inhalational meds, we can also put some directly into his blood through an IV. Through the IV, we can give him a continuous infusion of epinephrine for the beta agonism, as well as methylprednisolone and dexamethasone as their steroids of choice. It takes a while for steroids to start decreasing the inflammatory response, so we always have to get them in the system as soon as we can. His oxygen saturation starts to go back up, and he's slowly showing some signs of improvement. His intercostal retractions are becoming less pronounced, and his respiratory rate is starting to go down. That suggests that things are working. As things improve, we can slowly decrease his IPAP from 14 to 12, then to 10, and finally down to 8. But then, something unexpected happens. His wheezing becomes much louder. Does this mean we have to reverse course on the BiPAP? What's going on? Why are things getting worse again? Well, things are actually not getting worse. So don't freak out. Believe it or not, this is actually a sign of improvement. In a severe asthma attack, when the lungs start to open up again, they're starting to move more air, still with some obstruction, but things are actually starting to make their way through. That air squeezing through an obstructed airway is obviously going to create a ton of wheezing, so it's starting to sound really bad. It's paradoxical though, because this is actually what you want. Breathing with wheezing is exponentially better than without wheezing in this case, because it shows that the airways that were completely blocked off are now opening up to the point where some of the trapped air is starting to come out. So look for this as a sign of clinical improvement, not deterioration. After some time, things are really looking much better. His wheezing has steadily gone down, he's breathing slower and easier with a respiratory rate that has gone down to 16, and his oxygen saturation is now way up at 92%. And now, a huge milestone, he opens his eyes and starts to look around the room. This is a critical period for a patient recovering from a severe asthma attack. It is absolutely terrifying recovering consciousness in a hospital and feeling like you can't breathe at the same time. When your anxiety levels ramp up like that, you start breathing really fast. Our patient has made great progress, but he's not completely out of the woods yet. There's still some obstruction in the lungs. If he starts getting really anxious and breathing really fast, he's going to be breathing in all this air without being able to breathe it out. All our work to prevent barotrauma may become undone. That's why it's extremely important to talk to the patient, reassure them in a calm voice that things are getting better, but they have to stay calm. If absolutely necessary, you can give them an anxiety-reducing medication like ketamine. We really should avoid this if possible, because ketamine will sedate the patient. There's a huge value to keeping him off sedation so that we can monitor for mental status improvements, which is a crucial marker for clinical progress. After an hour and a half, he looks much better. He's speaking in full sentences, and his lungs sound pretty good on auscultation. His respiratory rate is down to 15 breaths per minute, and his oxygen saturation is up to 98%. He's monitored in the pediatric ICU overnight, and he did great. He was ready to be discharged the next day, all while never being intubated. In summary, you should never be rushing to intubate a crashing asthmatic patient, because ventilated asthmatics are at a very high risk of hyperinflation and barotrauma. Instead, you should immediately position the patient 90 degrees, apply BiPAP and administer nebulized albuterol, ipratropium, and steroids, and closely monitor for signs of improvement. When the patient does start to recover consciousness, it's absolutely critical that you reassure them to make sure that they're not getting too anxious and breathing really fast, because that's just going to cause air to build up in their lungs when they don't have a means of getting it out yet. And while ventilating the patient with BiPAP, we should make sure to keep the IPAP fairly low to avoid barotrauma and titrate it down as the oxygen saturation improves. Thank you very much for watching this episode of Medical Mayhem. If you enjoyed it, please like the video, share it with your friends, and subscribe to the channel. Until next time, this is Medical Mayhem.